Let me share and see if we get. See if I share the right screen this time. Are you seeing my slides? There. Now I'm on the title slide.
Yes.
Perfect. Now lost. I have lost your faces. All right. Well, I don't. Let's see. Here we go. There, I found y'all. I like to be able to see y'all a little bit. So we will just jump in. I don't think I'll go long today. I know I can like talk forever about this stuff, but I really think that I should end on time. So that means we have plenty of time for discussion. If you have worked on any of these things, please speak up. You can pop your information in chat if that works better for you. But if you tried some of these things, let us know whether it worked or not, because that's what the quality cycle is. We try it, we adjust it, we try it again, we adjust it, and it's continual change because nothing stays the same. And as tiring as that can be, that is really kind of the way of the world right now. So let's just jump in and go back to the learning objectives. So this is kind of just what we're going to look at, the hypertension and lipid guidelines and the CKM implementation guide. There is also, NAC also has a diabetes and hypertension guide as well. It's currently being re-reviewed and the updated version will be out soon. So we'll have that to look at too. It's similar to what it has been. And then the point of all of this is the things that are in the hypertension guidelines, the lipid guidelines, the CKM, which is cardiovascular kidney metabolic implementation guide, affect our UDS measures. They affect our value-based care measures, and they absolutely impact our patients and communities. So now just to kind of recap a little bit of the key changes around hypertension care from the March 2025 American Heart Association, American College of Cardiologists hypertension guidelines. And there's a whole list of all of the associations that were on with this new update. And so what kind of they have done is they have reiterated the tiers. The 130 over 80 is not new. That has been in place since I believe 2017, but they have just restated it. And they've made a little bit of a shift around terminology. They really emphasize that 130 over 80 goal, which if we get our patients closer to 130 over 80, we're definitely getting them under that 140 over 90 target. And we're reducing the cardiovascular damage and cardiovascular risk from that slightly elevated blood pressure. They have come out with the new Prevent calculator, which is different from the PCE that's used in the current ASCVD risk. Some health centers I do know have used that American Heart Association or Prevent calculation either through an app or a download on a mobile, things like that. So I do know there's a few out there that are working towards that. I put the question to Azara if they're going to be implementing that anywhere, and I haven't asked the right person that knows what the roadmap is, so I don't have any information on that. But because it goes along with the American Heart Association guidelines, they have all of the MAP information in there in Azara for reporting. They have all the million hearts in there for the reporting. I would guess that it would be coming, but I do not have confirmation on that nor a timeline. The there is a little bit of protocol changes in the blood pressure. There's a little bit quicker of medication acceleration to get that blood pressure controlled. And then there is some language around patient adherence, follow-up, and lifestyle changes across any stage of hypertension. And then another term change is around hypertensive crisis or hypertensive urgency. So that's a little bit of a high-level summary of what we saw in the hypertension guidelines. In the dyslipidemia guidelines, this is way bigger than I thought it was going to be. I think it's 125 pages. The previous lipid guidelines were very narrow and targeted. They did not have special populations. It sounds like a lot, and it is a lot, but they did not have guidelines around pregnant people and several other risk factors, and now they do. So that's where a lot of that is coming from. Some key things for general dyslipidemia, they have reestablished a hard numerical target for LDL-C. They've gone away from a percentage and they have very distinct cutoffs for where we need to target those for those that are at high risk, moderate or intermediate risk, and low risk. And those can be kind of low. For somebody who is very high risk, their LDL-C target is 55 milligrams per deciliter. So that is aggressive. The reason for that is because through doing this research on dyslipidemia, they have discovered that any elevation has a cumulative effect. It's not that damage starts when you get to a certain level. It's like as that goes up, each element that is higher adds up over time. So a slight elevation over 10 years has an impact on health. So that is what they found, and that is driving a lot of these changes. They have really encouraged early pharmacotherapy. There is some decision-making guides. It's like you can make decisions here. There are written in the guidelines where it's either or, and it is very much collaborative decision-making with the patient, but it also has very distinct guidelines on what their risk factors are and why the targets are what they are. So they also, and I like this, I actually like this, it makes it a little more challenging, but when we have patients come in and they have elevated lipid levels, they're like, well, I'll do lifestyle change. I'll exercise more and I'll eat better. And that's good. That's fine. That actually is something we need every single one of our dyslipidemia patients doing. But we have an endpoint for that now. When we do those lifestyle initial changes, we bring them back in 90 days. Has there been a change? If not, then it's time to add pharmacotherapy. It is not open-ended for how long you try lifestyle changes as its own single intervention to reduce lipid levels. And every person that has dyslipidemia that is part of what the treatment protocol is the lifestyle modification, the DASH diet, the increased physical activity, that kind of thing. And then they have also added on some criteria around families, familial hypercholesterolemia, which is where high cholesterol runs in families. They have screening in the very young. We skip puberty. During puberty, those bodies, male or female, during puberty, those bodies have kind of a suppression of the lipid levels because of what's going on with puberty. So we skip that time. When they hit, I think it's 21. Sometimes these numbers escape me when I really want to have them. But I think around 21, 25, if we didn't do it before they hit puberty, do it around 25 or late. If they've never had it done, go ahead and do it then. And what the point of that is, especially in those kids, those pre-puberty kids, is to identify that familial hypercholesterolemia, or there is another marker, I'm drawing a blank on it. I learned a lot with lipids on this, and a little bit of it is escaping my tongue right now. But there are two things that we're looking for in those kiddos so that we don't find when they are 25 that they have astronomical lipid levels because they had high levels when they were a kid because they have familial hyperlipidemia. And so it is early intervention to prevent dyslipidemia. And that's really a focus that all of these are getting to is do things early, do things to keep from progressing into disease instead of waiting for disease to develop and then treating. That is kind of an overall shift that we're going to be seeing. We see it some in hypertension. We see it in dyslipidemia. We see it in the CKM, and we see it in Life's Essential 8, which comes along with the CKM and the dyslipidemia guidelines, because that is looking at primary prevention, prevent it from ever happening. And really to keep from ever having any cardiovascular or metabolic involvement, we have to start with the kiddos. And when we do that, when we work with those kiddos and we can impact our childhood BMI percentile nutrition and activity counseling measure and be effective at their adult health when we integrate training for parents and adolescents and kids on why it's important. So all of these things are working together. And then also thinking about value-based care. Because as we move further into value-based care is coming. The CMS has stated we want every Medicare person and every Medicaid person in an ACO of some type by. They keep moving it a little bit later and a little bit later. I think we're in the 2030 something, 2035 maybe. It's also in the Rural Health Transformation Program is getting more Medicare and Medicaid patients into a value-based care arrangement, because what the point of that is not just to decrease costs, but to decrease costs by improving health. So these are some of the things that we're going to be diving in depth over the next year's worth of webinars. So let me see if I've hit all of my talking points there. Any questions so far? We're doing good on time. Do we have anybody in chat with a question? Where did my chat go? Nope, nothing in chat. Okay. Moving on to CKM, that's cardiovascular kidney metabolic syndrome. And what this is, it's staged, it's multi-system, and it's a framework for treating these things in combination. We all have seen, our patients have diabetes, they have hypertension, they have kidney damage. They go together. They exacerbate each other. So instead of treating each one as a single independent entity, because they impact each other, because they work with each other and are impacted by the treatment meds and such for the other systems, they have to be looked at as integrated. Not we talk about integrated behavioral health, integrated dental. Well, this is integrated disease. So that's just kind of pulling a comparison in. We can't effectively manage the entire patient who has a cardiovascular, a kidney, and a metabolic disease, any one or combination of the three. Once you get any one of those, you are more likely to develop the other two. So that is really what this implementation guide is about, is looking at it as a whole system process or a whole system disease process. Not, okay, we're going to take care of the heart. The cardiologist is going to take care of the heart. The nephrologist is going to take care of the kidneys, and primary care is going to talk with them about their overweight or obesity, their impaired glucose, their metabolic involvement in whatever stage it is, whether it's pre-diabetic or full-blown, we have these metabolic things going on. Side note, There was something that came out recently, and it just popped into my mind because I was talking about metabolic, but PCOS, polycystic ovarian syndrome. They have been doing a lot of research on that, and we'll probably bring this in when we're talking about metabolic stuff. They have updated the term for that because they are finding more and more that it has a very, very strong metabolic component of disease in that PCOS process. It's not ovarian driven. It is metabolic. And so that is something that I have seen recently. I just kind of wanted to give you a heads up. I know that in some of the nurse
7. So
chats, and you see where
do
you
I
can
just
get
come
the
in
things.
and work 11 and 7, or am I still working? Am I going to be working like a 7 to 7 shift? Or if
The so we'll look at that when we get into metabolic a little more. But I did know that it was very exciting on some of my groups that dealt with that because it's not just a reproductive sort of thing. It affects a whole lot of other things. So just a little side note, I try not to get too distracted, but we're doing pretty good on time. So I took the liberty of bringing in a an adjacent topic. All right. So life's essential aids. This is all the things that we think about as being healthy. And we also have to kind of think about, healthy isn't a particular thing isn't necessarily healthy, unhealthy. It's not necessarily an either or. We say all things in moderation, and that's true. So that I think we need to make sure that we keep in mind as we are working with our patients around these life's essential eight, keeping the kiddos healthy, improving the health status and halting the disease process in our patients that have active disease or are at risk for it. So looking at diet, looking at activity, looking at all of those different things and where they fall is important across the whole spectrum of age, the whole spectrum of disease processes. And for those of you that are in the rural health, RHTP, doing the community measures, this will be, you're not necessarily going to be using this as a reporting piece, but this ties into the CKM community quality measure that is included in the RHTP. Because that's in the RHTP, we're going to try and look at the CKM implementation first. Because just to be a time, not that anyone is more important than the other, but those who are working with the Rural Health Transformation Program in that CKM community measure, we just want to prioritize that because of timeliness. The reporting is going to be starting pretty soon. So that is where you're going to see that. That is your actual true preventive health care. That is where we do the things so that our patients can make informed decisions about how they want to live with an understanding of what impacts that may have down the road. I know that there are a lot of different patients in a lot of different spaces, in a lot of different mindsets with a lot of different abilities. That totally understand that. I am not trying to be idealistic that everybody can go to the gym for 150 minutes of exercise a week and they can all have their fruits and their vegetables and cut out refined carbohydrates, etc. I'm not meaning that at all. But if we're going to build a healthier community, we have to start with the youth as well and build that as we go. Look at how we're supporting our upstream drivers of health. If you met with me this month, that term is somewhat familiar to you. Upstream drivers of health is the new name from health-related needs, which was the new name for SDOH. So basically, we put a new label on the box, and I actually like this one. If we have enough time at the end, I'll tell you why. So Life's Essential 8, this is something that we will look at in conjunction with CKM, and it will support your patients, your staff's education towards your patient's preventive healthy lifestyle, and will support things around CKM. So that's also going to impact your patients with cardiovascular disease, your patients with kidney disease, patients with metabolic disease, because it looks at all those spaces. So let's put that all together. So what I did is I made a table, and hopefully you can read this. And this is the part I have all of these pulled together in a document. So you'll get this on like a PDF where it's all together in one document. So what I did here was I took each of these different kind of lifestyle domains, areas or kind of grouping things, and I put them on a table where we have Life's Essential 8 framework, the hypertension guidelines, the dyslipidemia guidelines, the CKM integration guide, and UDS reporting. So just kind of to look at things as a whole, zooming out just a little bit. We're not just going to look at how are we doing blood pressure rechecks, kind of zooming out and looking at how can I impact patients with hypertension or high blood pressure or my uncontrolled hypertensives list across all these areas. Because what we want to do is be efficient, right? We don't want to, okay, we're going to work on blood pressure. We're going to look at Life's Essential 8s and do that. Well, next, okay, let's look at the hypertension guidelines. Okay, well, let's look at this CKM thing Heather's been talking about. They overlap, they integrate, they enmesh. And so that's why I made this, is so that you can kind of look at it. I did use, I think it was Copilot to help me kind of put the framework there. I did some editing in it, but to kind of, okay, give me how to set this table up. So this is one thing that I did do with Copilot, and let me know what you think. I tried to read it. I have been trying out some of the AI things. Absolutely horrible for medical advice. I've asked it questions just to see what patients might be getting, and it's like, be careful. Check in with your oops, I went too far. Check in with your patients if they're coming to you with some interesting thoughts around healthcare, because AI has given some absolutely contraindicated answers to some of the questions I've asked it. So these are the free ones. The paid ones might be a little smarter, but I have always said computers are dumb, and I will throw them under the bus every time. All right, back to hypertension, blood pressure, cardiovascular. So in Life's Essential 8, our target is optimizing patients staying with their blood pressure under 120/80. And so how we do that is through diet and activity. That will also impact our hypertension guidelines, where our universal target is 130/80. And yes, we target 140/90. We have some patients with resistant hypertension. We have patients that have barriers to being able to change diet, change activity, change lifestyle, access meds. I totally get that. But are we doing a disservice by not also targeting 130/80 and being glad when we get them under 140/90? Because we have gotten them somewhere good, but can we get them somewhere better? So I'm not saying to be perfect with all the patients, but just be mindful that that target really is 130/80 for hypertension control. Using a dual pill. If they need two different medications, give them one pill. It definitely impacts medication adherence. And one other change around blood pressure guidelines is when a patient has severe hypertension and they do not have symptoms that are hypertensive crisis, such as an extreme headache, visual changes, etc. If they have severe hypertension and they are not showing those crisis signs, then that reduction in blood pressure is titrated outpatient. Dyslipidemia guideline directly overlaps the blood pressure control, because that is a major driver of cardiovascular risk and impacts dyslipidemia, and dyslipidemia impacts it. The CKM guideline integration, that takes them both together. That you are looking at your cardiovascular system, your blood pressure is elevated, you are having microvascular damage done to organs, kidneys, and then you are looking at, are we developing kidney disease from hypertension because we've got microvascular changes because we've not gotten that blood pressure controlled? Are we having organ damage to other organs? And is that impacting body systems, primarily metabolic systems? And then by looking at this, it directly impacts our hypertension measure because, like I said, we are targeting 140/90. And I'm this might be a bad opinion, but I kind of want them to leave the UDS guideline or the UDS quality measure where it's at. Because our patients have so many other challenges, getting them below 140/90 is good. I'm concerned that we would have a whole lot more trouble, a whole lot more or not more, a whole lot lower levels of hypertension control if that were to be moved in line with the new guidelines. Kansas, I was looking at this yesterday, and Kansas, for everybody that is in the HCCN that has a Zara, your overall network hypertension control rate went up by 2% over last year, and we are only in July. So good job. That was awesome to see. Speaking of Zara, we'll get into some of Zara reports. But how do we know which patients? I need to back up just a little bit. I got a little ahead of myself with the Zara. You know, I'd like to jump into that toy. So if we're going to work on these things, if we're going to work on dyslipidemia, if we're going to work on cardiovascular disease, if we're going to work on metabolic disease, if we're going to work on preventive care, we got to know who we're working with, right? And there's lots of different ways. I talk about Azara primarily because that's what I have access to. I am fully, completely aware and completely supportive of those of you that do more reporting out of your EHR. I don't have access to it, so I can't speak to it. So that's why you hear me talk about Azara a lot more. So are you using EHR alerts or the Azara PVP to identify these things? Are you pulling recall lists to call these people in? And not necessarily just, oh, we haven't seen this hypertensive patient or this diabetic patient for 6 months. We need to get them in. We haven't seen this hypertensive patient yet this year. Or this hypertensive patient, their blood pressure was elevated. We made a med change. It's been a month and we haven't seen them. Are we bringing them in to do that closer monitoring until we get them stable in a controlled status with their disease? So, like I said, I have these are reporting, so that's what I'm going to give you. I know that your EHRs have good reporting too, so this is not at all to knock your EHR and your other tools, but there are 8 hypertension control reports, 14 hypertension monitoring reports, and 8 hypertension prescribing reports. And that doesn't count, like for controlling hypertension UDS measure, there's all the different versions. I only counted that one because I would expect that we're probably using the most recent, the most up-to-date report. So that's where all that is coming from. And I want to look a little bit and stay with me. I am not calling out any one health center. So this is to demonstrate something. So stick with me. This is looking at, I built a filter with the 30 different hypertension specific reports. Does not include, for those of you that are in the early KCN group that have the payer integration model, this list does not include your HEDIS measures, but for, I think, 5 of you, those are available because you are in that payer integration early adopters group. So this is our Azara report use. We have 156 reports of controlling hypertension. And our next closest is confirmatory blood pressure. So that's your, was it high? Did you check it again? Did you recheck your blood pressure? So, and that can also be an alert and an alert closure. No, wait, no, that wouldn't, because it would not be an Azara yet. I'm mistaken on that. That would have to come out of your EHR. But anyway, just kind of take a little look through here and see what some of these are. I put this in here so that you would have it as a resource, because I know it can be challenging to find any one specific report in Azara. So this is here for a resource. Now, this is kind of the breakdown, and there are no names here for a reason. This is the breakdown of what I just showed you, those hypertension reports by health center. And what I want you to see here, health center that it has the highest rate of control. The bars are reports run. The numbers are ranked hypertension control. So the health center that's ranked first has the highest number of reports. Okay, that kind of makes sense, right? But look, the second highest run, the health center that's run the second highest number of hypertension reports is the number 16 on the ranking, and that is not bad. Like I said, everybody. I mean, we've got that secondary target. It's like 65. And we're at or over that for every health center. So nobody is doing bad here. But what I want you to look at is reports rank. Reports rank. They don't. Now I know I don't have your EHR reports here. But what I'm trying to show here is it's not just reporting, it's not just getting the lists, it's the process. Without a process to use the data to focus where we can be effective and make an impact, we don't get anywhere. So what this is about is looking at what data do I have, how can I use it, and what is my established process that we do ongoing in order to move that hypertension control measure outcome. So that's what this is about. It's not just data, not just process. We've got to have both. All right, let's move on to dyslipidemia. So this, cholesterol, lipids, dyslipidemia, this is going to look across that at the, 5 different new things that we've had that come out around all of these health conditions in the last, a little over a year. So around cholesterol and lipids, the general target for patients is 130 unmedicated. We're good there. I will say with a caveat that if you have that familial hypercholesterolemia, your target's going to be a little different. This is your regular average Joe or Josie off of the street that doesn't have any other risk factors or any other things going on. So that is our target. That's where we want to have people naturally through doing the lifestyle, the essential aids. That is done through looking at lowering the red meat consumption, lowering fat consumption, plant forward nutrition. There's a little bit of different thoughts around that, and that's fine. I'm not trying to say we need to dictate to all of our patients that they need to go vegetarian or anything like that. I would be very sad. But this is more around not building our diets around red meat as the main thing on our plate. It doesn't say don't have it, but kind of look at how it impacts long term, and then talk with our patients, our members, their families around these type of things as overall healthy lifestyle. The hypertension guidelines, these dietary and lifestyle interventions that we're talking about in Life's Essentials 8 and around cholesterol and lipid management lifestyle changes, that also supports lowering blood pressure levels. And so by focusing on that side of things, we also have an additional impact on our blood pressure control. We do have the hard targets. So these are the hard targets for the LDL-C in the dyslipidemia guidelines. Before it was kind of a percentage, so you could get a little fuzzy with it. This is a straight number. So let's see, looking at CKM guidelines. So this is really kind of a big thing in the CKM guidelines is getting cholesterol levels under control because that drives cardiovascular risk by a lot. Not only that, but the statins can be protective. By being on a statin, you can stabilize any plaque that's already there, reduce the chance of it breaking off, and that's a good thing. So that is where that kind of works with this. And then, of course, we have our statin therapy for prevention of cardiovascular disease. That's a UDS measure. That is one of those complicated measures where if you're this, then this is your target. And if you're diabetic, it's this target. And if you're over this age or under, you got tiers. So it makes it a little challenging. But all of these things that we're working on, Life's Essential 8s for healthy lifestyle, hypertension guidelines for diet and dietary lifestyle, lowering that lipid level through the dyslipidemia protocols, the CKM interventions, all of that is going to impact your statin UDS measure. And in a way, it could possibly impact your IBD measure because when do we fall into the IBD measure? After we've had a blockage. There's some other things. But if we can prevent them from having a blockage, we prevent them from having that health condition, they're not falling into that denominator. And I don't know, not having a heart attack sounds kind of good to me. So there we go. Any questions? Where are we at on time? We're still pretty good. Don't see anything in chat. All right. So just like I said, I'm pulling out reports so you can see them at a glance and kind of see what we've got going on. I found this was kind of interesting. I was like, this is the statin measure report utilization. What were we doing in 2023? I was looking at this and I was like, we did something in 2023. What did we do? I'm really asking, guys, because I'm like, what was that? Anybody know what we were doing around lipids in 2023? When was Azara rolled out? For some health centers, it was rolled out well before COVID. I think we've had somebody implement every year or maybe every 18 months since I came to community care in 21. Yeah, that was like, that really caught my eye. So I was like, did we have a initiative or a project that I forgot about? Because we need to do it again. So that's where that question came from. Let's see. I can see it by center when I go into Azara. I generally don't like doing that on these because I don't want anybody to feel put on the spot. But yep, I'll be looking into this a little more. And if any of you can think of what your health center was doing in 2023 around lipids, y'all were running a bunch of reports. So, all right. Let's move on to metabolic and diabetes. So, hyperglycemia, impaired glucose, impaired metabolic, actual diabetes of whichever persuasion, other than, corticosteroid-induced diabetes. But these are what we look at for diabetes and impaired glucose. We want that fasting glucose under 100. We're not going to change the lab reports, but we have bodies are not the same. And so knowing that, okay, so somebody comes in, they're not feeling good, their fasting glucose is 110, but they're not feeling good. And they're telling you signs of hyperglycemia. Yeah. We got to also keep in mind the number doesn't tell the whole thing. We got to look at the clinical picture. So, that's our target. That's where we'd really like to be. But that number doesn't tell us everything. So we also need to look at what our patients are telling us and put those together in a clinical picture. We're starting to hear that more and more around some women's health things, around some anemia things. And so I think that is going to be something our patients are talking to us more about. It's like, well, this, the internet said that XYZ, it's normal within this range, but it's optimal to be up here. And so I think we're going to start getting some more conversations from that because I've been seeing it on out on the internet. I go out there and see what's going on. 'Cause it's like, what are they talking about now? And that's one of the things they're talking about now. So on the hypertension guidelines, losing weight, changing our diet, changing our activity, that is going to impact our patients with diabetes. There have been patients who have worked really hard, have done a lot of work around dietary modification, weight management, and their diabetes has become less acute or they've gone into remission. And yeah, nope, all right. That's really awesome. And there is a diagnosis code for remission for diabetes. I don't think the recommendation is that if the patient no longer is showing the criteria for diabetes, that you end the problem, like you don't resolve it, it's in remission because they have that diagnosis doesn't go away, it's still underlying that. Talking about glycemic, we talked a little bit about blood pressure control to manage microvascular changes in the kidney and the organs. Same thing with glucose. We have that elevated glucose. It's causing microvascular damage or microscopic damage in the kidneys and other places in the body. And it could be beginning undetected neuropathy, undetected eye or vision changes, all of those things. So by managing the glucose levels and managing their diabetes, then we have more protective processes going on then. There is also a movement towards leveraging the GLP-1s and those type of things for cardiovascular, kidney, and metabolic disease. I have a research paper somewhere that I got a hold of that it shows in data, in a chart, I mean, it is objective information, that a group of diabetic patients was put on a GLP-1 and they had no change in their diabetic status, but they had other changes in their other health systems. And so it showed that even though they, no, I'm sorry, their weight didn't change. So even though they were on the GLP-1, their weight didn't change, their diabetes, their cardiovascular status, that changed. And so I know it's kind of hard to get those GLP-1s. There's lots of different hoops to jump through. There is that new Medicare program, the Bridge program, which I've seen a lot of misinformation around that out there. It is, I think the more we get into this, in future years, that will become more and more an expected treatment modality than a lucky or privileged modality. And I don't know if I'm using the right words there, but right now it doesn't seem like it's as available to everybody as, say, insulin and metformin. So I think that is going to be an area that's moving. And then, of course, working with glucose, diabetes, A1C, all of that is going to impact the UDS diabetic measures. And then it took 2 screenshots to get all the diabetes ones. And there are a lot of diabetes reports that you guys are running, which is awesome. So now we're going to look at a couple of more reports that are in Azara. I forget about these, and it's easy for me to forget about these because you have to have PHI access to see these reports. So this is the Diabetes Care Effectiveness Report, and this is a big report. It has, well, I've got them listed in another slide. But what this is showing right here, it's kind of our color wheel. Can you see my mouse where I'm pointing? Maybe. This kind of breaks down the percentage of the population in various different levels of glucose control. This looks at it by diabetic patients and their blood pressure control. And then it gives you the average blood pressure and the average A1C. And then the change. Is that the change, or am I thinking about the other one? This is a little bit tiny. I'm sorry. Yep. This is patients with an A1C that's dropped by 1.5%, and this is patients with a 10-point drop in their blood pressure. And it's a little bit hard to see this bar down here, but this is going to show you the patient. So that's why there's no data here. I clipped it off just to see the headers. Last 12 months, what was their A1C? What was their blood pressure? What was their, and it breaks it down by diastolic and systolic. This one is very similar. This, nope, this is the same one. There's two. There's a Diabetes Care Effectiveness Report that is basically the top of it with a little bit more operational type data. So that is good for operational use. This care effectiveness patients is where you can find your target patients. I did not get the care effectiveness report on the slide, so that apologize for that. That's what got me a little bit confused. So continuing on from what we were seeing before, we've got the demographics, first A1C, most recent A1C, et cetera, et cetera. And on this, this is the whole network. So this is a huge number of patients. But, it'll be your diabetic patients. And this does look back a little bit further. It looks back like 5 years for a foot exam, 5 years for an eye exam. And so if you want to run a work list for your location A, you can add a filter for location. You can add a filter for provider. You can also come down and add filters down here. Now you can't see it, but these little colored dots, these are going to be down here in your A1C, that status. That's what that's going to be. And you can filter. It's like, I want to see all of my patients with poor glucose control that, let's see, that have had an increase. Will this do increase? Maybe. Oh, sorry. Trying to scroll on my notes and I scrolled the PowerPoint. We want to see our patients with poor control. Say they have no appointment. So who's uncontrolled that doesn't have an appointment that we need to get back in? And you can see clear down on the other end their most recent visit. So you can also put filters on each of these columns. If you want to see who has their most recent A1C here in this result column, you just hover right here. It's going to give you those three little lines, the little hamburger, the ellipse, whatever we want to call that. Click on that and it's going to give you the ability to sort highest to lowest or filter to pull out a specific set. Now you got to be careful putting too many filters on because you might end up with nothing, which I have done. You can also filter down or make this report smaller by pulling columns out if you don't want to see those columns. And then you can save it so it's a one-click to go on there. So that is kind of how we can do this. Let's see. All right. Any questions on this? This is a very robust report. A lot of information, so I definitely recommend doing some filters, some sorting, some looking at what population you want to target first. But the cool thing is it lets you do that. All right, so these are all the columns that are on that particular report. And let's see, how did I get these clear at the end? These were supposed to be a little earlier. Sorry about that. So this is looking at the kidney and metabolic health. The life's essential aids is the same thing. The hypertension, we've talked a little bit about that. We know that the hypertension, the high elevated blood pressure causes damage to the kidneys. It can impact the metabolic screening. But now we have some target organ screening in the hypertension guidelines. So we want to look for hypertension damage. Dyslipidemia, we're looking at ApoB and LP little a. That's how this is said, LP little a. And these are things that cause elevated risk in our patients that need to be addressed. Looking in the CKM is looking for screening, dual screening for kidney function changes. And by looking at all of these, we don't report a kidney disease quality measure, but we do kind of have an impact on a couple of other measures for patients that are having kidney damage, like their blood pressure is elevated. They have resistant hypertension because they've got some renal disease going on, and their hypertension is being pushed by what's going on in the kidneys, and that's where the focus needs to be for treatment. So that is a little bit on the kidney and metabolic domain. And then weight and physical activity. We talk about this a whole lot. And we know as a country that overweight and obesity is becoming a very, very prevalent disease process. And our bodies have changed over time, over years. The bodies of our great-grandparents are not set up the way our bodies are now. We have had the environmental changes, the food changes, what we eat changes our brain chemistry of what we want with food. Oops, that doesn't need to be there. There is an increase in eating disorders, even among, we tend to think of eating disorders as the young high school girl that is either exercising to skeletal size or binge purge in the bathroom. But there's more to it than that. And so those are the things that we'll look at more as we get into this. What else is going on with our patients that are struggling with overweight and obesity disease? And it is not something that can be willpowered out of. Obesity and overweight is not caused by a life choice. It is a true disease process. And we can't change the culture of the United States overnight, but we can start chipping away at it, at least in our patient population, and how we approach our patients that have overweight and obesity disease and help them to improve their health and support them through that. So that'll be another thing that we get to through the year. And that is the end of my slides. I did not run over, and we have time for questions. I have shown you my ideas of what we're going to look at over the next year around the guidelines and implementation guides. What did I miss? We don't have those evaluations after these things anymore for you guys to tell me what I missed and what you want to hear. So I'm going to be asking you. I might be asking you at our meetings, but if you can pop that into chat or come off of mute and let me know, what do you want to see in the next year's worth? Remember, our grants all reset right now. So when I'm saying next year, it's the next 6 sessions of this webinar. What do you want to see around hypertension, dyslipidemia, metabolic disorder, chronic kidney disease, preventive health? What do you guys want to see? Joseph, I see you came off of mute. Oh, you went back. Oh no, I thought I was getting a suggestion. I do very much value you guys' input in the content that I bring to you. So if you think of something, 5 minutes after the call, shoot me an email. I'll start asking you in our one-on-one meetings. But that is all I have for today. If there's no questions, I'll let y'all go just a few minutes early. Thanks, everybody.